Perfect. Good evening, all. I am Dr. Sanket Nevale, representing Medical Affairs at Wockhardt Limited. I welcome each and everyone to this series of webinar that we are starting from today onwards, which would be a weekly webinar series called as iTrust. And to inaugurate that, we have our key speaker today, for which you would just have to wait a few minutes for me to introduce him. I would first like to take you through what Wockhardt is all about and what it has done. And followed by that, we will have our speaker to be introduced. The agenda for today's meeting would be very simple. We would start with the welcome and introduction. Followed by that, our speaker today, Dr. Hirani sir, would be taking us through the presentation. And then we'll have a Q&A session followed by closing or vote of thanks. Now with that, let me start with a brief introduction of our company, Wockhardt Limited. A safe harbor statement for any investors listening to me. Please have this disclaimer in the background. Now, Wockhardt has 11 manufacturing facilities across the world. It has 12 R&D centers, one each in India, UK, and USA. Approximately 520 scientists with more than 80 PhDs, discovery team, the drug discovery team of more than 150 associates with us. More than 20% of the 5,400 global associates are based outside India. 3,214 patents filed and 793 patents granted. Revenues of up to 1,973 crores. International business contributes approximately 75%. For the global footprint, you can see our businesses in UK, emerging markets like Latin America, Africa, Asia, CIS, and MENA. In India, it's the first Indian company to launch NCE. More than 800 of field force in India. In Ireland, it's amongst the top 5 generic companies, largest generic companies in hospital products. In US, it's present as generics in hospital segment and in pediatrics. Our capability across different segments, if you see, we have more than 5,000 employees. It is across US, EU, India, and emerging markets. We deal with solids, liquids, injectables, nasal sprays, biotechnology products, and complex technologies. The divisions we have are antibiotics discovery division, we have biotechnology, we have pharma generics as well. And our share in the individual markets, as you can see below, is approximately 32, 20, 25, 6, and 13 respectively. When it comes to novel antibiotics, we have a committed research of more than 20 years to novel antibiotic research. Number one, probably only company to have comprehensive end-to-end drug discovery programs in antibiotics. 6 programs granted a QIDP status by US FDA, denoting an unmet needs, faster trials, quicker approvals by the US FDA. If you see, this is the global footprint where you can see a shrinking pipeline, a result of scientific challenge and missing discovery talent base. On the right top corner of the screen, you would see the legends as launched and in pipeline. And if you see on the extreme left, the first column where Wockhardt is listed with 5 new chemical entities, out of which 2 are already launched, named as MROC and MROC-O. We have the 3 upcoming NCEs like the WCK4873, WCK4282, and WCK5222, which would be reaching the market very soon. On compassionate use of WCK5222, which you must have seen in multiple newspapers as well, recently under the DCGI permission, 3 patients in India with life-threatening infection received this NCE, which is under development, which is WCK5222 on compassionate ground, and since available antibiotics were not efficacious. Patient 1 who was given this drug in September 2022, who was a 50-year-old female admitted in Medanta Hospital, Lucknow, who was treated by Dr. Dilip Dubey, had only 10 days of therapy with WCK-5222, was rescued, the patient paving for discharge in stable condition. Think about it. There was no other antibiotics which was working, and in 10 days, WCK-5222 rescued the patient and discharged in a stable condition. Now, second patient who was given the treatment in December 2022, the patient was an 11-year-old boy admitted in Global Hospital, Chennai, and the treating doctor is Dr. Ponni and Dr. Subramaniam. Here, 2 weeks of WCK-5222 eradicated the pathogen, discharged again in a stable condition. And patient 3, who was under treatment, 18-year-old male admitted in AIG Hospital, Hyderabad, and treated by Dr. Balasaheb. Here, in 10 days, WCK-5222 eradicated the pathogen and being treated for cytopenia. With this NCE in the pipeline, I would just like to take you through our steps. So 5222, which is in phase 3 and global studies, potential indication being chronic UTI, HABP, or VABP, with the positioning of destination therapy for XDR, gram-negative, Acinetobacter, and Pseudomonas. With WCK-4282, again at phase 3 global, with indications similar to WCK-5222, position for empiric use or carbapenem-sparing gram-negative pathogens. We have phase 3 filing in 2023, the WCK-4873 positioned or potential indication being CABP or an RTI, with the positioning of macrolide-resistant respiratory pathogens, quinolone sparing. And lastly, MROC and MROC-O was launched in India, and in EM, its filing is underway with the potential indication of ABSSSI and positioning with MDR gram-positive anti-MRSA medication. Lastly, WCK-6777 is currently in the phase 1 with the potential indication of chronic UTI and positioning as outpatient therapy for MDR gram-negative. For WCK-4873 and MROC-O and WCK, we are looking forward for partnership in different regions. Now, key highlights of the India business. If you see, the therapeutic focus is across diabetes, nephro, anti-infectives, pain or analgesics, vitamins and nutrients, neurosciences, and CNS, and others. One of the few Indian companies who are into manufacturing of insulin, glargine, and OSD in diabetes. Robust distribution network with more than 20 CNFs or stockists or distributors, with approximately 2,000 distributors across the nation. Only Indian pharma company to launch a novel NCE in India with the brand name of MROC and MROC-O. On 9-month basis, diabetes biosimilar business grew by more than 20% and launched sitagliptin under brand name Sitawalk. The vision of pharma, vaccines, biologics, and new drug discovery is right in front of you, and we are looking forward to establish a good footprint when it comes to the focus in diabetes as a biosimilar, diabetes injectable portfolio, insulin, glargine, EPO, and patented devices, and diabetes biologicals market, which is as huge as more than 50 billion. The competitive advantage by providing end-to-end solution in diabetes biosimilars is R&D in terms of focus on insulin analogs and GLP-1 analogs, in terms of manufacturing, pilot to large-scale capabilities for API and formulations, regulatory in terms of registrations in more than 25 countries, and in terms of devices, customized, precision, patented delivery devices that we have, like the insulin pen, vials, cartridges. And also pipeline for insulin analogs, including insulin aspart, that you would see the light of the day very soon. Lastly, we are talking about international presence. We talk about our contract with the UK government for fill finish supply for AstraZeneca's University of Oxford COVID-19 vaccine, where his ministry government, we have in combination with AstraZeneca, Wockhardt has supplied more than 60% of all COVID-19 vaccines in UK. 14% of AstraZeneca in Europe, and more than 90 COVAX countries. You can see in the photo below on the bottom left corner, Charles and ex-Prime Minister Mr. Boris Johnson, who was there in Wockhardt facility and reviewing our vaccine, that is the vaccine COVID-19 that we provided for the population of UK. On the right side of the screen, you would see Serum Institute and our partnership with them for a long-term profit-sharing arrangement. And with that, I would now complete by saying that with Wockhardt, we impact life. We try as much in our research to save lives and be an affordable products for all our consumers and doctors, and for our stakeholders, being a listed company, to give as much strength and profit and confidence in Wockhardt. With this, now I would like to introduce our speaker today. We have Dr. Atul Hirani. Sir has completed his M.B.B.S. from Wockhardt and dedicated his career in the field of diabetes since the age of 26 years. He has underwent 2 years resident clinical and research fellowship in diabetology under the world-renowned diabetologist, globally acclaimed diabetes research scientist and Padma Shri Professor Dr. V. Mohan at Chennai. He is winner of the Torrent Young Scholars Awards in 2019 as Best Orator Diabetologist in India. Part of a prestigious Distant Mater Class Trainings 2021 in Diabetes Technology, Diabetes Therapeutics and Technology from Joslin Diabetes Center, Massachusetts, and Boston University in USA. In 2022, associated as Global Trainer of Faculty with Time in Range Academy at Park Nicollet International Diabetes Center, Minnesota, in USA for advanced training on CGM applications and research. Certified from International Diabetes Federation School of Diabetes on Diabetes and Ramadan, accredited by the European Accreditation Council for Continuing Medical Education, EACCME, in 2020 in collaboration with Global Diabetes and Ramadan Alliance, UAE. Completed course in gestational diabetes mellitus endorsed by the South Asian Federation of Endocrine Society. Authored original chapters in national and international textbooks on diabetes associated organ complications, expertise, special interest, and experience in diabetes monitoring technology, and involved with research on use of technology in optimizing diabetes care. Dr. Harsh is a serial healthpreneur, that's what he calls himself, as an ambassador, youngest business coach, and network trainer of Business Networking International, Hyderabad region, India, transforming business journey of CEOs, CFOs, proprietors, and MDs of business houses across Twin Cities. So without any further ado, I would like to get our Best Orator Award winner, Dr. Harsh Hirani, on the dais. Over to you, sir.
Thank you so much, Dr. Sanket, for the kind words of introduction. At the outset, I'd like to congratulate Team Wockhardt on continuing the innovation of research and development in lots of spectra of therapeutics. So without any further delay, I'd like to acknowledge Wockhardt for initiating such interesting conversations. And today, we are going to speak about the insulin initiation as being one of the cornerstones in diabetes management therapy. So this is how we are going to have the agenda so forth. So with this, we'll begin with first understanding the epidemiological status, the burden of diabetes, both global and Indian perspective. Following that, we'll be discussing the more focus on early insulinization as an intensive early insulinization. Following that, tackling the barriers which clinicians face in initiating and adopting insulin in clinical practice. And then the last will be the clinical elements which are to be considered when initiating insulin, the drug interactions, the drug titrations, and so on and so forth. So without any further delay, I'll start with the epidemiology. So this is one slide we have been seeing over last 4 years, and since the IDF Atlas, in fact, in 2020, when they published this global statistics, again followed up in 2021, we can clearly see a massive rise in risk of diabetes in Southeast East Asian region, and the increment is 68%. And apart from that, when we see the prevalence of it being in respect to worldwide, in 2045, the estimated count of diabetes, persons with diabetes, is going to cross 152 million. And even more shocking is what we have learned recently in the April, which I'll be taking in the next slide. But before that, at this point, prevalence, if we see for a number of people with diabetes aged 20 to 79 years globally, if we see 1 in 10 people are having diabetes, and that counts to 537 million people. 1 in 18 adults have impaired fasting glucose. So these people are going to become pre-diabetic and then will be at risk of becoming a diabetic. 3 in 4 people with diabetes live in low and middle income countries globally. 1 in 2 adults are undiagnosed with diabetes. So it's about like 50% of people having diabetes don't know that they have diabetes, and 6.7 millions are deaths are attributed due to diabetes. So we were all worried about the deaths attributed to COVID and other pandemics, but then diabetes already has been taking a huge toll when it comes to the end complication related deaths. When we see about global health expenditure, 11.5%, staggering 11.5%, which is close to 966 US billion US dollars. I mean, 966 billion US dollars. The number itself is so huge, is attributed towards the management for diabetes. And when we talk about India, 1 in 7 adults have diabetes, so which is close to 74.2 million at this point, and more than 53% of people with diabetes are undiagnosed, almost matching the global stats. And per day, we have close to 2,768 deaths due to the diabetes-related organ complications. So this is like, the burden is 10 billion expenditure on diabetes-related care has been used up. So moving on the studies, right from the 2014, the trend has not improved. So if we see 2014, one of the landmark studies called DiabCare studies from my mentor, Dr. Vishwanathan Mohan's team, and following up in 2019, another study from Dr. Soma S. Das, both of them have clearly shown more than 20% people, just out of 100% diabetics, only 20 to 23% people have been under the A1C of 7, which is very, very dangerous, because all these other 80% of people who are not in control are at increased risk of end organ complications. And that again increases a lot of toll on expenditure in healthcare. And following that, in 2020, one other study from Dr. Nikhil Tandon's group has again shown that only 16%, the latest one has shown only 16% people have type 2 diabetes with A1C of under 7. So all these figures are very frightening, and they're true, actually speaking. So despite the benefits of good glycemic control and several treatment options, that A1C levels are often not met. So in fact, this is what I was mentioning about a couple of slides back. In April 2023, just recently, 2 months back, we have officially been projected to overtake China as being the most populated nation by the end of this year, where we'll be crossing 1.428 billion. So now all the numbers what we saw, all this 150 million by 2045 and all these, may prove wrong, and we may reach those numbers little early, considering this explosive figure. So it is very important to understand the intensity of the problem we are in right now. And talking from Indian perspective, when it comes to the delayed insulinization, it is one of the factors. The inertia towards intensive therapy is one of the factors of worsening of outcomes, what we have observed over the decades. And when it comes to the triple therapy, more than three therapy, dual therapy, there's a consistent progressive change if we can observe in terms of number of tablets and the percentage of achieving of A1C of 7 under the 7. At the same time, prescription pattern, if we see, again, insulin is something which has really struggled as being the mainstay, unlike other countries where very often it's initiated on time at the right time and the complications are averted. So clearly, insulin initiation is often delayed in routine practice, and there's a need for an early and intensive approach to the type 2 diabetes management. So now we'll be talking now that we have understood the impact of the diabetes on epidemiology, as well as on the risk of the expenditure of not treating it on time or in an intensified way. It's important to understand why early insulinization. What are the benefits? What's the evidence? So clearly, the two landmark studies, UK-PDS and DCCT, where intensive therapy have been followed up prospectively, have clearly shown that if the approach to diabetes management is early intensive approach, the diabetes related deaths and all cause mortality as well as myocardial infarction has significantly reduced in the arm of intensive therapy. So clearly you can see right from 1977 to 1997, and even on a follow-up study up till 2007, those benefits have been sustained. It's not just like, okay, one time intensive initiation and then benefits were seen for a few years, and then again it didn't have any long-term impact. But clearly we can see a long-term impact even at the end of 20 years. So legacy effect, this is what we call as legacy effect, which has been associated with intensive glucose control in patients with diabetes long after the cessation of randomized intervention as well. So even after the trial got complete, post follow-up trial of 10 years also yielded significant benefits due to this early intensive therapy. So the short-term intensive insulin therapy has also been linked with glycemic remission. And from several meta-analysis right from 2013, we have observed that there has been a possible remission happening towards the end of 24 months in such patients. So this short-term insulin therapy right at the diagnosis has shown to produce remission of diabetes in close to 45% of newly diagnosed type 2 diabetes when identified correctly. So people are talking about reversal. The last 5 years, reversal has been like the fashion in diabetes world. But friends, reversal is again, it's a very important point to understand that a complete reversal is when a diabetes is completely gone without the support of medicines, without the support of any intervention. That's when we call it true absolute reversal, which is hardly 7 to 8%. What others are happening and what claims are made are remission. Now, these things are being talked now, but then if you go 10 years back, we already have data of glycemic remission happening with early intensive therapy. And this, friends, you'll be shocked to know, this is not just from the developed countries. Even in developing countries, even in countries spreaded across the world, such evidence is there over the years. So moving forward, early intensive insulin therapy at the time of diagnosis in the identified cases, the eligible cases, has clearly shown that beta cells get a resting phase, due to which there is a restarting of beta cell function, which has been observed. And clearly it has been proven on paper as well, on numbers. So it has been shown that clearly significantly it could improve beta cell rest for a consistently long period. So starting with one of the first studies done in 2009, so almost more than 15 years back, so where a study from China has been done, where clearly the near normoglycemic remission was observed with long-term maintenance of beta cell function. And in fact, one of the longest duration we have observed has been up to 5 years of beta cell function preservation. So basically, you're delaying the worsening of diabetes by 5 years by timely intensive initiation at the time of diagnosis for a short course, not even for the duration of a year or so. So moving forward, we even have study coming in from Korea, which was done in 2010. Clearly, we could see an improvement in C-peptide. You can see the C-peptide metrics here. So the acute C-peptide response post the early intensive insulin therapy clearly because of beta cell resting. So beta cell being numb, gone into paralysis when rested, has shown to rejuvenate beta cell function over time by clear-cut improvement in the C-peptide response. So again, here also we are seeing it significantly positively remitting diabetes in cases. So coming to our very own Indian study, one of the first Indian studies, again by my mentor, Professor Vishwanathan Mohan, and a group with Dr. Mokta from Shimla, clearly they've done in 2018, where again similar study was similar outcomes have been observed, where mean postprandial C peptide significantly increased by this early intensive insulin therapy at the time of diagnosis, leading to rapid improvement not just in glycemia, but even it helped in maintaining long-term normoglycemia and an improved sustained beta cell function. So again, a very significant data from India. Following that, again in 2018, one more study got published from China with a very large cohort, where again a similar outcome was seen on improvement of beta cell function, and it was preserved. So here the cherry on the cake was, along with early intensive insulin therapy, even sitagliptin was used. It was used as a follow-up therapy, and clearly we know that see here there is a double, the cherry on the cake, where the first benefit what we get is the beta cell preservation due to the intensive therapy. The second is due to sitagliptin. DPP4s, clearly we have seen that even DPP4s have shown to preserve the beta cell function over the years. So it's a double-edged benefit what we have here with this consideration at place, where over the years it has been seen to have a sustained control. So then comes one more study from one of my colleagues, Dr. Siddhant Madani from Allahabad, where again a similar study has been done, where clearly a short insulin therapy just for the duration of 4 to 6 weeks has shown improvement in beta cell function, again verified with C-peptide improvement and sustained improvement of C-peptide, both fasting as well as post-meal, even at the end of 2 years. So from India, this is one of the only studies where up to 2 years, a consistent C-peptide follow-up has been noted, documented, and we have seen a consistent improvement in the function of beta cells. And the diabetes is also towards the remission state. So again, one of these studies from my mentor and my colleague, Dr. Siddharth Madnani, and Dr. Mohan and Dr. Ranjit Unikrishnan. So all these studies clearly prove the fact, they are proof of concept, what we discussed a few slides back, of early intensive therapy. So again, one of the studies by Professor Shashank Joshi's group in 2020, one of the recent ones, similarly had shown a significant improvement with long-term benefits of optimum glycemic control. And again, at the time of initiation of diabetes, if it was started, there was a very excellent metabolic memory extended with positive legacy effect benefits. So with this, all these points move forward to the fact that this concept has things which have been tested around the globe, and we have seen the improvements being consistent. So most of the organizations are now, whether you take RSSDI, whether you take ADA, all of them have advocated the fact, and that in cases which are eligible with such glucolipotoxicity, in early insulin therapy at the time of diagnosis has clearly yielded long-term benefits and is recommended. Moving forward, going on the proof of concept. So enough of theory. Like now, let's see something clinical, real time. So this is now we are going to talk with CGM. So CGM is a technology of 24-hour glucose monitoring, a continuous glucose monitoring system where we exactly find what's happening, whether hypos, the sugars being on higher side. So there's no hideout, like it's a 24-hour data, much reliable than a conventional old-fashioned, static information based analytics of diabetes. So when we see about CGM, here we get a 24-hour glucose fluctuation pattern. You can see the timeline here. At the same time, we even see the average glucose of 24 hours. And the most important element is time in target. That is percentage of 24 hours. The sugars have been in the designated range of control. So for this patient, 80 to 160 is the designated range of control which has been targeted. So at this point, when the patient has been diagnosed, it is 0%. And this is the entire 24 hours average of sugar readings. It is not a single reading, but it's an average reading. It's a mean reading. Now, this particular case, what we are going to discuss is a classic glucolipotoxicity case. Such cases have increasingly emerged over the last 10 years in our practice. And we have here A1C of 15.7, and the fasting sugars are above 400, postprandial in the range of 550 to 600 at the time of diagnosis, and triglycerides are hoofing 1150. Literally, the blood of this patient is turbid pink, not red, turbid pink, because of hypertriglyceridemia. So this is a classic situation of glucolipotoxicity. And friends, here in this particular case, the beta hydroxybutyrate, which is the ketones, is negative. So it's not a case of decay. Neither there is osmosis symptoms, but it's a classic glucolipotoxicity situation. And here the intervention which has been used is a biosimilar U100 glargine along with a metformin and a DPP4 inhibitor combination at 2 times a day. And in this particular case, the DPP4 which has been chosen is sitagliptin. And we can see what happens in the next few days. So clearly on Wednesday evening, you can see the initiation of the U100 biosimilar glargine insulin. And within next 48 hours, you can see the time in range, as in time in target, significantly improving. You can see from 0% of 24 hours in the sugars being in the designated range, closely within 48 to 72 hours, we are seeing a stable hypoglycemia free improvement in 24-hour sugar control. So friends, this is a real time picture of sugars getting stabilized due to early intensive insulinization, which is leading to a beta cell rest, improving the outcomes. And in these cases, I mean, in one more case I'm going to show, in both these cases, the course of insulin is just 6 weeks, 1.5 months, that's it. And that to a single shot of biosimilar U100 glargine, a basal insulin, a peakless insulin. So you can see a stable improvement. And naturally, the prandial corrections, the insulin resistance is being addressed by the metformin DPP4 combination as well. But moving forward, a similar case I'll be showing where there's again glucolipotoxicity. Again, A1C is hoofingly high, 14.2, and again triglycerides are 1079. So friends, here we are able to see not just the glycemic correction, but even the lipotoxicity is getting addressed here due to the insulinization. So because insulin, as we all know, it addresses the catabolism, anabolism dysfunction as well, which also reduces the inflammatory markers, which also has positive outcomes on the lipid dysregulation, which has happened, stabilizing not just the sugars, but even the metabolic profile of hypertriglyceridemia. So along with that, a similar intervention with the glargine U100 is initiated. Here, if you see, the postprandial spikes are slightly higher. So the choice of combination of orals is again DPP4 inhibitor with metformin, but vildagliptin is chosen deliberately because we all know vildagliptin has slightly faster onset of action compared to sitagliptin. So if we are targeting a better prandial correction in such cases, that's something which has its own role in action. So clearly, similarly here also you can see when glargine U100 is initiated, within 48 hours, you can see the time in range improving significantly. All the way it's improved to 36%, 70%. So globally, as per the standard consensus, more than 70% of 24 hours of your sugar control in the designated range of time in range should be there for a person to be staying in normoglycemia. So significant improvement you can see in real time. So friends, this was proof of concept. So earlier we saw in a trial-based structure in a controlled, atmosphere how the assessment was happening on utilization of early insulin therapy. But now we could see even in the clinical patients, in clinical practice, in real time. So this is like the most realistic way to see the effect of the toxicity getting corrected. Again, in 2017, a very important editorial has been written in Journal of Diabetes, where pros and cons both have been checked in. So again, we talked all about positives, but then there also has to be a discussion of cons of this short-term insulin therapy, right? So starting with pros, as we discussed, The beta cell function improvement and reduction in insulin resistance has been there with short-term insulin intensive insulin therapy. At the same time, in cases who are morbidly obese, GLP-1 receptor agonist it leads to non-inferior A1C reductions compared to basal insulin. At the same time, you could lose weight also. So in these cases, the approach has to be slightly tailor made, and again, a strong A1C reduction can be anticipated in such cases as well. So the other pro, what is in terms of potential mechanism, if we see, is de-differentiated beta cells getting redifferentiated to mature beta cells after insulin therapy. So this de-differentiation beta cells to redifferentiation, and then again the beta cell restoration of function is one of the pros. And when we see the lower baseline, the target of control is to push down fasting better. Cases of fluctuating weight loss where there is osmosis, all these cases, the benefits have been yielded better. Again, when it comes to acceptability, there are challenges in the treatment satisfaction and other aspects. But then again, the cons here is reluctance. So the barriers, what we are going to discuss in the next session, are the cons for this kind of therapy. Again, cost is a metric which is different in different countries. And here the hypoglycemia tendency is lower, contrary to the belief, but because we are using a basal insulin, we are not considering a very powerful basal bolus regimen at this time. And again, the con could be the hypoglycemic events definitely being little higher than an oral agent in this case. But then if the tailoring is done in choosing the correct type of insulin in such early intensive insulin cases, type 2 cases, the outcomes are very pragmatic. So now comes the talk on the breaking of the inertia towards the timely insulin initiation, which was one of the cons. So this inertia, if we see over the years of duration of study, where one of the studies from Italy, which is by Prato del S, clearly here we have seen that over the duration, if the early insulin or early intensive therapy as a modality is offered at the time of diagnosis, not just 5 years, not just 10 years, but even at the end of 15 years, the legacy effect is sustained. Because if we keep on increasing one agent by say 500 to 1000 milligram, 50 milligram to 100 milligram, if we keep on increasing one agents versus if you give an intensive therapy at the time of diagnosis, the results are just mind-blowing. And this is not just true in one countries, but globally this has been observed. So getting to glycemic goals early leads to better outcomes in people with diabetes. So clearly there's no debate here, because legacy effect has been seen not just in UK-BDS DCCTs, but even in the follow-up post-trial completions up to 10 years, we've seen that. So again, as I was mentioning about the recommendations from RSSDI, where clearly if it has there's a failure of multi OHA, instead of adding a more fourth agent, insulin definitely is the preferred choice. And again, when though there are several new oral agents available, their glucose lowering potential is still challenged when compared to insulin, because no matter what we say, insulin has been there for last 101 years and it still stays the go-to approach when it comes to the A1C reduction. So that now comes the barriers. So now we had all mushy talks, all the good talks about the insulin. Now let's talk about the challenges. What are the challenges in initiation time, adoption of insulin? So when we talk about initiation and adoption, the challenges during routine clinical practice we face is the inertia, the lack of training, lack of time and availability of team, the social stigma, the psychological resistance, lack of understanding about the cost effectiveness, lack of tools to monitor, and as well as the awareness. So the monitoring awareness itself is a big challenge. We see a lot of patients where they've checked only one sugar, one fasting for 10 days, they'll show and bring it with your glucometer. So effective communication on even on monitoring and awareness on monitoring, that you have to take a multi-point SMBG readings, or advocating the use of CGMs in people who can afford it. All these things lead to a better outcomes in diabetes and prevents a lot of complications. So again, when it comes to adherence and complexity, the complexity of a regimen and multiple injections are one of the key factors in determining good adherence. So if it's a simple, once a day insulin, clearly there has been a better adherence compared to a 2-shot or a 3-shot insulin regimen. So, and this has been consistent across the world because the studies have been summarized as a meta-analysis from China, France, Japan, Germany, Spain, Turkey, UK, and the USA. So all these developed countries have seen this. So clearly, we also face similar challenges. Now comes the practical solutions to overcome these barriers. So when it comes to fear of injections, the simplest solutions is now we are no longer in 1990s or even in 1970s where we have long, thick, painful needles. Practically speaking, if we convince or communicate the patient in the right way, if we make them take first dose of insulin, as in just 1 unit of a demo dose in front of you, stating that it's painless, actually it's painless. It's about the perception. The fear perception of injection is also one of the factors where people are unnecessarily scared. So one common practice we use in our practice is let them have first dose of a demo shot of insulin from a pen at the center, and clearly you communicate that it's not going to pain because the needle thicknesses have drastically changed in last 5 years due to the improvement in technology of engineering for the insulin pens, the insulin needles. Clearly there's been a significant paradigm shift in the comfort of using these needles, which was not the case 10 years back. So again, when it comes to adherence and complexity, the long-acting insulins are easy to be administered at bedtime because they're flatter insulin. The basal analog insulins are much flatter. They don't have peak like an NPH insulin. This really makes it more easy in initiation. And again, the pens make the administration much easier. So fear of weight gain, again, clearly we've seen that the modern analog insulins, the modern basal analog insulins have shown a very negligible or a very lesser weight gain compared to the older generation conventional ones with the NPH and so on and so forth. And now because things are going off patent and we have much more biosimilar options, even the cost factor is addressed very efficiently in our country. So again, use of concomitant antihyperglycemic therapies that can taper down weight gain is again an additional benefit. So lifestyle modifications again can be advocated a little differently in persons on insulin so that the weight gain can be minimized at the same time getting the benefits of a sustained improved glycemic control. When it comes to the fear of hypoglycemia, again, because they are flatter insulin, they don't have peaks, the serious hypoglycemia incidences are rare. Nevertheless, the hypoglycemia education and awareness is again a very important cornerstone of this cornerstone, especially when you're considering to initiate insulin. The hypoglycemia awareness and education is extremely important. And novel insulin formulations clearly have shown lesser hypoglycemia compared to the older generation ones, and they can be prevented. So now we see a lot of misinformation, a lot of negative information on insulin. More than 90% of which is utter nonsense all around, whether you take social media, whether you take general perception of insulin. So it's very important to counter the misinformation by actually talking the scientifically proven evidence-based benefits of insulin therapy. So unless this communication is made, there's no point even in this whole talk which we are all investing our time close to 45 minutes to 1 hour what we're going to invest. So it's very important to discuss the benefits of insulin. So first and foremost being it's not a tablet, it's a hormone-based therapy which has been there for 101 years. So there's no therapy on this planet which was given Nobel Prize within 2 years of discovery, being such a lifesaver discovery. So that itself speaks of volumes of the perception of insulin therapy. And we even have data from Japan, we have data from Netherlands, we have got data from Germany, where clearly we have seen that insulin, if initiated at the right time, in the right cases, actually have shown to prolong the life of people with diabetes. So a lot of publications have been done in this. So starting with the benefits, the first important benefit which we often fail to communicate is the increased healing ability of the body. So when you take even the exogenous insulin, there's a factor called IDGF, which is insulin derived growth factor, which gets stimulated even at the time of exogenous insulin therapy, which helps in wound healing. The beta cell function improvement, which we could clearly see in the early insulin therapy cases, we saw in the two cases. At the same time, we even saw in the trials, which would clearly see a beta cell functional improvement, and that improvement stayed. It's not that it was an improvement for 1 month, 2 months, or 3 months. We have data ranging from 2 years up to 6 years. The largest one being up to 5 years of beta cell function sustenance post considering early insulin therapy. And these are all not just hearsay data; these are actual documented C-peptide validated data. And even the C-peptide standardization have been different in these data, different as in the more accurate one, because these are in controlled trial situations. So many a times the counter question, can we C-peptide standardization, is a challenge. But friends, these research centers where these data have been created are not just normal labs. These are all ICMR accredited centers globally. The other countries where they've done, they are their government regulated labs. Moving forward on the protection, so there's a lot of misinformation nonsense on insulins damaging the organs. But again, we have seen over the time that in cases of glucotoxicity and such critical cases, insulin is a lifesaver, because in cases of CKD, insulin is the only safe therapy. And in cases of neuroprotection, again in cardioprotection, it's one of the major elements of therapy where it has shown over time to have a protective effect. In fact, one of the landmark trials have been done even on insulin analogs, where cardioprotectivity has been established. So when it comes to the neuropathic symptoms, again they've shown to significantly reduce and improve the quality of life of persons with diabetes. Now, the most important one being the muscle health. So, friends, there is a lot of sarcopenia which is under discussed, under addressed, even at the time of diagnosis in such glucolipotoxic cases, in severe hyperglycemic cases, where insulin again has shown to improve the muscle health over time when initiated at the right time due to its anti-inflammatory properties. And the shift in the catabolism anabolism dysfunction, what insulin does, also has been shown to be helpful in this. So this is the communication which is often not done in the right way, which creates a lot of inertia and resistance. So after tackling the barriers, now we come to the last part of my talk, which is going to be on clinical aspects of insulin therapy. So when to consider insulin, we already discussed. After OAD insufficiency, so more than failure of 2 to 3 OADs, definitely it's a considerable option. GLP-1 receptor agonist being very costly, but if somebody can afford, could be the first injectable therapy in patients with uncontrolled on OADs with ACVD as per the new guidelines, where there is a high risk of hypoglycemia, and also where people are obese, where weight loss is desired. So this is one exception where we can give the benefit of doubt to GLP-1 receptor agonist before considering the insulin on board. So insulin and diagnosis, which is what the major chunk of this talk today has been on, the early insulinization therapy. So again, we saw a lot of data. We saw the clinical evidence on this as well, where A1C is more than 10. Definitely, it can be considered a confirmed type 2 diabetes patient with A1C of more than 10 is an ideal candidate for this. And again, when we talk about glycemic factors, these ratios have been little outdated, but then again, if the fasting to A1C ratio is more than 20, definitely it is a simple metric to consider insulin therapy. Again, if the postprandial increment is less than 18, yes, definitely a basal insulin could be considered here, so that you avoid unanticipated postprandial, I would say postprandial, the delayed hypoglycemia, what we see often with the conventional older generation insulins. So typically, this hypoglycemia has happened at fourth or fifth hour post the insulin dose. That's why we say postprandial hypoglycemia. So this can be averted where the prandial increment is less than 18. So again, there the basal insulin stays the choice, where it doesn't really have a fast-acting component to address the prandial control. Again, these psychosocial factors, somebody is challenged with the day-to-day needs, limited literacy, simplicity, and easy to adapt regimen is again a basal insulin, which we've seen over the decades. And again, the phase of life, So now this is again very important in children, again with type 1 diabetes. So this is not type 2 specific, but this I'm specifically mentioning in terms of type 1 diabetes. Again, a basal bolus therapy has been a cornerstone. So again, we see a lot of cases just on 2 times premixes and maybe a one shot of short acting insulin. Friends, this doesn't work for long. I mean, basal bolus is the most physiological regimen when it comes to type 1 diabetes in children. And the patient who is an adult with early stage of disease, again, here a basal insulin can be considered. But again, in a pregnant person, somebody with GDM, gestational diabetes, towards the end of the pregnancy, because of increased in requirement of insulin, basal bolus may have to be considered here as a therapeutic regimen. And when the control of only fasting plasma glucose is needed in elderly people, again, this is where the basal insulin is one of the safest choices. So all 4 different scenarios in respect to the phases of life we just discussed. Moving forward, in resource deficit settings, what we face many a times in our practice, future intensification is more simpler when we consider basal bolus therapy or even a basal plus therapy. Again, a very underutilized therapy where one shot of insulin of fast acting you give with the heaviest meal, and the rest is taken care by the basal. So again, this is much better than considering a 2 shot of a premix. So if the patient consumes lesser amount of carbohydrates in the other meals other than the one with plus therapy, again, this could do wonders and reduce the risk of hypoglycemia again. So moving forward, when it comes to the basal insulin to basal plus, which I just mentioned a couple of minutes back, or a basal bolus regimen, patients who need dose titration or flexibility are ideal in these cases. And the patients who are in the acceptance stage of more frequent injections, and people who really need increased self-monitoring are to be watched out for this insulin initiations, because there may be unanticipated hypoglycemias if meals are not in synchronized with the therapy, or if the wrong insulin is taken at wrong time, because there are multiple shots. Very often we see this also as practical challenge. So this is where education of self-monitoring has an increased role here. Again, basal insulin to premix insulin, this is again one thing where the carbohydrate counting, where it's cumbersome and where we are just not able to fix the lifestyle habits of a person. Again, this is the only option we have. That is also one of the reasons why we see so much of NPH human combination use in India. So again, in these cases, we don't have much choice but to augment this together. So patients who prefer fewer injections, less frequent monitoring due to lack of education or lack of seriousness towards the disease, who may have diminished ability to inject, so limited manual dexterity. We often see this in dementia cases, old age cases. In these cases where prandial control is a challenge, premix is definitely a better option compared to the basal one. So with this, when it comes to the switch, like when we are switching, again, the simplicity of regimen is one of the key elements. And if we consider basal insulin plus GLP-1 RA, this is like a golden combination. So in patients who prefer once a day injection, at the same time, patients in whom less weight gain or we don't want weight to gain by any trigger factors due to lifestyle or any other reasons, where we actually want a weight loss, somebody who is obese and where there's high risk of hypoglycemia, the switch from basal to basal with GLP-1 RA can do wonders. Because we have seen over time that when GLP-1 RA individuals are the GLP-1 RA initiation happens in obese people who are on basal insulin, the basal insulin requirement has shown to fall down. Close to 30-35% of basal insulin goes down when initiated in someone, when GLP-1 RA is initiated in someone on basal insulin who is obese, where insulin resistance is one of the factors at play, and along with the beta cell dysfunction. Again, premix to basal bolus, in case of failure to achieve the target, we should consider it. Also in type 1 cases, I repeatedly quote, basal bolus is the golden milestone in a better, stable, long-term control. So moving forward, when it comes to oral drugs, it's again very important to be very careful when we are using sulfonylurea, because when we consider just the basal insulin, which is an OD dosing, the modern sulfonylurea is not the older generation, but the newer generations like glyclazide, probably glimepiride, can be continued, but with precaution and with education to follow up after a certain period of time, so that the down titration of this sulfonylureas can be done. So again, in premix, the doses have to be reduced for sure of sulfonylureas. Otherwise, many a times we see unprecedented cases of hypoglycemia. And the worst part is, in some of the cases, there is something called hypoglycemia unawareness as well, where a person may be floating at sugars of 65, 60, but then the symptoms may not manifest. In fact, we had a couple of cases where sugars are less than 50, still there were no symptoms. So there's a complete autonomic failure, or complete loss of body's ability to manifest the symptoms of low sugars that we see in many cases. So SUs are a red caution. We have to down titrate as per the case to case basis when required. So when we are on premix BID dosing, a short acting sulfonylurea can be considered with the third meal where insulin is not there, with appropriate monitoring. When it comes to TZDs, they can be used with insulins. In fact, TZDs have shown to reduce, the dose reduction has been seen here. So the symptoms, the adverse event risk is also reduced here. And it has to be discontinued in cases with symptoms of cardiac failure. And in cardiac failure cases, we generally don't recommend TZDs anymore. AGIs can be used with basal and premix insulins. DPP4s can be used. Clearly, we could see. And if GLP-1R is not part of the therapy, which is what is there in major cases of our country, because GLP-1RAs are still very expensive, so DPP4s can be used. SGLT2s can be used for better control, but then, friends, we have to remember the SGLT2's ability to bring down early morning sugars, particularly 4 a.m. to 6 a.m., which is your pre-fasting time. So SGLT2s have a strong effect on lowering your fasting sugars very efficiently. So again, you may have to down titre the dose of insulin by frequent monitoring using the SMBG. So again, it's very important. It may help to reduce insulin doses, because it also helps in reducing the insulin resistance. So that could go pretty well with this combination. In addition to insulins, in patients with type 2 diabetes and established atherosclerotic cardiovascular disease, or indicators of high ASD risk, CVD risk score, or someone who is obese, this can go very well. And again, GLP-1RAs, we already discussed this. In cases who are obese, if added, the insulin dose has shown to significantly reduce and create long-term better outcomes. So now comes the last slide of my session today, where the decision cycle for the patient-centric management of type 2 diabetes has been shown. One of the most important slides. Once we identify the patient categories, once we consider the specific factors which impact on choice of impact, a shared decision-making management plan has to be there in confidence with the patient. The imposition of treatment should not be done, but a collective decision-making with an agreed management plan, and then the implementation and a systematic, educated monitoring of sugars, and then a follow-up systematic plan. All these, if clubbed up in an efficient way, can lead to groundbreaking outcomes in care of diabetes individuals with type 2 diabetes. So with this, I would like to conclude my talk and take up any questions. Once again, I would like to acknowledge the Wockhardt team for this amazing initiative, and Dr. Sanket for outright approach in hosting this session. So with this, I end my session with the quote from Alvin Toffler, one of the great futurists from US. And the illiterate of 21st century will not be those who cannot read and write, but those who cannot learn, unlearn, and relearn the facts. With this, I conclude my session. Thank you so much for your patient listening.
Thank you, sir. That's an amazing didactic session that I've heard. It was a story. It was a smooth journey that we saw. Thank you for that. We have one raised hand in the audience with us. I'll just like to unmute and ask him to speak or take his question. Mr. Rajendra. Dr. Rajendra, sorry. Dr. Rajendra.
Rajendra, you can unmute yourself and ask the questions.
I've asked him to unmute. Dr. Rajendra, if you can hear us, and if there are no technical problems, request you to unmute. And
Now,
yes, Dr. Rajendra, please go ahead.
thank you very much for such a illustrious explanation of initial insulin therapy in type 2 diabetes. I want to convey that if at the initial stage, as there is a glucotoxicity and lipotoxicity, it has a shut-off effect on the pancreas. So pancreas doesn't work at that time. So if you start insulin and bring down the glucose, the pancreas will get time to recover and will respond later on. So initially, if you give oral hypoglycemic drug, it will not work as insulin. This is my notion. What do you say?
Very well said, sir. Exactly what you said, we discussed in our, I think, 18th or 19th slide, where I could show the real-time evidence of what you're saying on CGM. So completely agree, sir. We have been seeing it in many cases where insulin, if it's preferred over oral agents, it does groundbreaking results. And the best part is not for a few months, but for years and years, the beta cell function is preserved. So completely agree, sir. Thank you for your positive point here. Right.
Thank you.
Thank you.
Thank you, Dr. Rajendra. Sir, we don't have any more hands up, and we have crossed our time of 8:30. So I would like to invite our lead, marketing lead here, Mr. Vishwa Gaurav, who would like to give his vote of thanks. Over to you, Vishwa.
Thank you, Dr. Sanket. So before I give my vote of thanks, I just wanted to share a news with all of the delegates and our respected Dr. Harsh. So here on the screen, that this year we are celebrating 20 years of Wosulin. In 2003, Wosulin becomes the third brand of the world, and Wosulin put India on the global map of insulin manufacturers. So in 2003, India became the third manufacturer of insulin after US and Europe. So Wosulin makes India proud. So I would like to extend my heartfelt thanks to all the doctors who have supported the Wosulin and who have guided us to take the Wosulin forward. So with this, I would like to, it's my privilege to extend my heartfelt vote of thanks to all those who have made this event a resounding success. So I would like to begin by expressing my deepest appreciation to Dr. Harsh A. Hirani for his insightful and thought-provoking presentations. His expertise and knowledge have enlightened us on a subject of utmost importance. We are truly grateful for you, sir. And I would like to express my heartfelt appreciation to all the delegates who have attended this webinar. Your active participations, insightful questions, and valuable contributions have added immense value to this gathering. And I would like to extend my sincere thanks to Dr. Sanket for his exceptional moderation skills throughout the webinar. And my special mention goes to our IBB President, Amrit Medhekar sir, for his vision and leadership that have made this webinar possible. And my gratitude extends to LCS Sri Vishnu sir, who is cluster head of diabetes business, for his support and guidance in organizing this webinar. Lastly, I would like to express my gratitude to all the diabetes division field team and all my actual colleagues who have worked tirelessly behind the scenes, which ensure the smooth execution of this webinar. So concluding here, thank you all once again, and I look forward for your continued support towards Wockhardt iTrust webinar. And before we sign off, I would like to share that this webinar is also available on demand. And if you would like to review this webinar, YouTube channel is there. You can go to our YouTube channel and see this webinar. And also a mail will be sent to all the registrants, which contains a link where you can see this webinar. So thank you again. Thank you very much, Dr. Sanket. Thank you very much, Dr. Harsh. And thank you very much, all the delegates, for being a part of this webinar. Thank you very much.
Thank you, Vishwa. With this, let's conclude and meet again on 10th of June for the next webinar on the topic. We have barriers to initiate insulin therapy. So with this, signing off for this week, meeting you again next week. With that, wish you a great week ahead. Thank you all. Thank you for coming.